Okay, welcome everyone to the oral surgery questions discussion in the NEET Grand Test 4 that you have all given in the eGurukul apps. Alright, in the eGurukul website, you all sat down and you have done the NEET Grand Test 4 in the latest pattern. And today we are here to discuss the questions of oral surgery. Okay, I had put some questions directly repeated from the NEET 2024 paper, some questions from the INI May 2023 paper, so that you get a good revision of all these questions, plus some new questions also. Alright, so let's look at each and every question one by one. Okay, the first question is, while extracting an impacted mandibular third molar, severe bleeding occurs due to incision over which of these structures? Okay, so now we know that the correct answer to this question is buccal artery. Alright, I'll tell you how. Okay, so this is your impacted mandibular third molar. Alright, this is your wisdom tooth and this is your second molar. द टिपिकल इंसिशन जो हम देते हैं अपने विजडम टूथ एक्सट्रैक्शन में इज द वार्ड्स इंसिशन. ओके, व्हाट इज द वार्ड्स इंसिशन? वार्ड्स इंसिशन इज बेसिकली अ रिलीजिंग इंसिशन just distal to the second molar. Alright, after that we give a straight incision over the alveolar ridge, and sometimes if required you can give one more releasing incision slightly buccally. Okay, not going straight but we go slightly buccally. Alright, so this will give a kind of a trapezoidal flap. Okay, is image mein there is a triangular flap. Why there is a triangular flap? Because they have not given a posterior releasing incision. उन्होंने सिर्फ एक releasing incision दिया है, which is the anterior releasing incision. Anterior releasing incision, and we've all discussed this in our live class very nicely. We continue this incision on the alveolar ridge, and sometimes we give posteriorly a posterior releasing incision also. Okay, and this is what we typically call as the wards incision. Now, what are the two complications that can happen in the anterior releasing incision? If you are going too deep or too inferiorly, you can injure the buccal artery. And similarly, in the posterior releasing incision, if you are going straight rather than going slightly laterally, if you go straight, you can damage the lingual nerve. These are the two facts you have to remember. A lot of MCQs revolve around these two structures. Anterior releasing incision, buccal artery. Posterior releasing incision, if given straight and not taken laterally, will cause injury to the lingual nerve. Well, that is why the answer to the first question is buccal artery. Okay, identify the instrument shown in the image below. Now, many times we have discussed this question that it's a giggly saw. Alright, I thought this is a good opportunity that I show you the giggly saw that I usually show in the morning motivation session. Okay, so this is the paired handles of a giggly saw. Alright, it's a T-bar, T kind of an instrument, a T handle, a thin straight metal handle and a hook. Alright, this is a hook. If you can all see, this is a hook and it's a paired instrument. So these are two hooks. So what do we do with this? We attached it to a barbed wire. Barbed मतलब ऐसे कांटे वाला एक तार होता है. It's a stainless steel wire जिसमें barbs हैं, कांटे हैं. So what we do is we fix one loop of the wire to one handle. We fix another loop of the wire to another handle like this. Alright, and what we have ready is a very quickly cutting instrument, a quickly cutting saw. Alright, so if I have this mandible, right, this is a mandible and God forbid there is a tumor here, an ameloblastoma here. If I use a burr to resect my mandible, it will take a very long time. It will take 10, 12, 15 or even 30 minutes depending on my experience. But if I take the giggly saw, if I put one end medially like this, if I put the other end laterally like this, okay, so I have both the ends of the giggly saw attached to my mandible in this fashion, like this. Alright, so one part of the wire has gone medially, other part of the wire has come laterally, okay, and I fix this loop of the giggly saw with my handle and zoop, zoop, zoop. I just move the handle of the giggly saw 2 or 3 times, and within seconds the mandible is resected. Alright, so this is a giggly saw, very commonly used in cancer cases, very commonly used by ENT surgeons and plastic surgeons and whoever is doing oral cancer resections. Alright, a large amount of hard and soft tissue resection is performed in cancer excisions, and very commonly they use the giggly saw. Like for example, like I said, if this is a tumor in the mandible right here, one part of the wire will go buccally, another part of the wire will go on the inside lingually, and quickly, like a rasp, like a saw, you can cut the mandible this side and then on this side. So it's a very quick method of resection. Okay, conventionally, if you have to resect this much mandible like here, what we use a burr. We use the same micromotor burr that we use for a wisdom tooth extraction, but that's really slow. Okay, we do that to prevent injury to the soft tissues. But when it's a carcinoma case, when it's a cancer case, you have to sacrifice a lot of soft tissues also. So in that case, you can very easily use the giggly saw. Alright, so the answer to this image-based question is giggly saw. Identify the fracture in the image below. I am not even discussing this. We all know it's a LeFort-2. I am sure most of you have marked it correctly. If the line of fracture was something like this, a Guerin or a dento-alveolar region fracture, it was LeFort-1. This pyramidal shaped fracture is LeFort-2. And if the fracture would have been like here from the, zygomaticofrontal region to the orbit to the medial side, something like this, causing a cranio-maxillary disjunction, then it would be a LeFort-3. Alright, so this is a straightforward, easy question, LeFort-2. Again, this question, we have all discussed it multiple times. The image is showing a very straightforward cyalolith, alright, which is kind of jutting out into the oral cavity, and they want you to identify whether you know that this is a cyalolith. And just by ruling out the options, you can mark the correct answer. Alright, now what are the options? Such calcified structures are infrequently seen in the parotid gland and duct. Very true. It is infrequent. That means it is rare to see cyaloliths in the parotid gland and the parotid duct. Most common site of cyalolith is the submandibular gland. We all know that. Alright. So this answer is correct. So it is not wrong. Okay. We have to find the statement which is not true. Option number B is straight short course of the submandibular duct and thick mucoid secretion increases chances of submandibular gland and duct cyaloliths. Now the second half of the option is correct, that the secretions are thick. But this first half of the option, straight short course, this is wrong. Alright, so not even the full option is wrong, just the half option is wrong, which makes B as the correct answer. Somewhere here, if this is your mandible, I mean not yours but some patient's mandible, and this is the submandibular gland, and the gland duct opens into the floor of mouth somewhere here. So the duct has to travel a very long and tortuous route. It's a very long route as compared to the parotid or the sublingual glands, where the duct length is also short and it is straight. Whereas the submandibular gland, the duct has to travel a long distance and it's not a straight course, it's a tortuous course. So straight short course, wrong. Tortuous long course is the correct answer, which is why the option B becomes wrong and that becomes your answer of choice. Calcified concretions cause swelling and pain in the region during meals. Absolutely correct. That is what the symptoms will be. If the concretions are small, concretions means calcified collections. That means these cyaloliths. अगर ये छोटे हैं तो हो सकता है asymptomatic हो. If they are intraparenchymal, that is within the gland, हो सकता है asymptomatic हो. In that case, no treatment is required. But when they become symptomatic, when they obstruct the duct, they become symptomatic. And what are the symptoms? Symptoms are simply pain and swelling. Why pain? Because the saliva is being produced, it is being pushed, but it is not able to come out. So it causes pain. Because the saliva is not able to come out, it causes pooling and it causes swelling. Alright, and these collected saliva can also get infected. So it becomes an infected cyalolith which can even form abscess. Alright, so swelling, pain, tenderness, abscess, these are all the symptoms that you can see with the cyalolith, and only these symptomatic cases will require a treatment. Cyaloliths can also be seen in minor salivary glands. Yes, very, very rarely, but you can see cyaloliths in the minor salivary glands also. Alright, they are not of much significance, but the only wrong option here is option B. Okay, so that's how in many situations you have to rule out an answer and come to the correct answer. You have to rule out options and you have to come to the correct answer. Okay, coming to question number 5. An 8-year-old boy, remember the 8-year-old is very, very important here, comes with bilateral TMJ ankylosis. So like we have discussed in our live class also, whenever it is a childhood ankylosis, it's very severe because the child is still growing, the child is developing, and in this stage it will cause facial asymmetry. In this stage it will cause airway compromise. So childhood ankylosis, severe consequences. Similarly, when it is bilateral as compared to unilateral, if bilaterally there is ankylosis, the consequences are very, very severe in forms of facial cosmetics, that is facial deformity, and in forms of airway. Both these things are not there in an adult ankylosis. In adult ankylosis, there will be no facial cosmetic changes because growth has already happened. In adult ankylosis, whether it is unilateral or bilateral, airway is already established. Okay, so there is usually not a big airway compromise. Okay. There is usually not a very big airway compromise in adult ankylosis. But whenever there is a childhood ankylosis and whenever there is a bilateral ankylosis, it is really, really a problem in airway and facial cosmetics. Now coming to the next part of the question. The child gives a history of snoring, excessive snoring, continuous waking up in the night, and daytime somnolence. So all those who have listened to the obstructive sleep apnea lecture, OSA, you all know that these are typical features of obstructive sleep apnea, which is one of the very common complications that early or childhood TMJ ankylosis can cause. Okay, so OSA is very commonly seen in patients, young children with TMJ ankylosis. So what will be the treatment? Now whenever you have an airway affected, your priority changes from opening the mouth to making the airway better. ठीक है, अब आपके लिए airway is more important. Mouth opening, yes, the treatment for oral ankylosis, TMJ ankylosis is opening the mouth, either via gap arthroplasty, via CCG, via distraction, whatever. But here, your priority is to improve the airway and to correct the OSA first. Alright, so in this situation, there is a protocol which you should all learn. This is a common protocol that we use in cases of TMJ ankylosis with obstructive sleep apnea. Okay, an adult patient can also develop obstructive sleep apnea because of other reasons. When he is obese, when there is hypothyroidism, because of so many reasons. Okay, so whenever there is TMJ ankylosis with OSA, you have to decide what is the severity of OSA. Severity of OSA is dependent on apnea hypopnea index, AHI. Alright, we do a polysomnography, we do a gold standard test for OSA, which is polysomnography, and based on that we decide what is the AHI or the apnea hypopnea index, and based on the AHI score we decide the treatment modality. Alright, now this is the three things you have to remember. First, whenever the AHI is more than 30, whether it's a child or adult, always do distraction first. Now, what do we mean by distraction? Remember, there can be two types of distractions in TMJ ankylosis. This is the mandible. This is the ankylosed part. Okay, so the distraction that we do to recreate a new condyle, this transport disc that we create and we distract upwards till we reach the glenoid fossa, this is also a distraction. Okay, this is known as TDDO, or transport disc distraction osteogenesis. This distraction we are doing to generate a new condyle. The purpose of this distraction is to generate a new condyle. That's a reconstructive option. Okay, but the distraction that we do for OSA, for correcting the obstructive sleep apnea, is not this distraction. In cases of TMJ ankylosis with OSA, if this is the mandible, this is ankylosed, this is ankylosed. Okay, we will do another type of distraction which is known as body distraction. We will do osteotomy here, we will do osteotomy here, and we will distract this anterior mandible forward. Okay, it's a simple linear osteotomy and distracting the mandible anteriorly. You can do a body distraction, you can do a ramus distraction here like this. You can do increase the length of ramus, you can increase the length of the body region of the mandible, or nowadays a lot of auto distractors, a lot of multi-vector distractors are available. So what you can do osteotomy in the angle region. In the angle region you can distract like this also, so that you can increase the height of ramus. You can distract antero-posteriorly also, so that you increase the length of the mandible, that is you bring it advanced, and you can even rotate the mandible. So this distraction osteogenesis that you do in the ramus and body of mandible, that you do for correcting obstructive sleep apnea or for facial cosmetic changes. Basically, this is the distraction that the examiner is talking about. Another type of distraction that you do is TDDO. That distraction is done for reconstruction of condyle. That is just a functional rehabilitation that you are doing after the condylar mass, ankylotic mass is removed, and to create a new condyle you are doing again distraction, which is TDDO. But before TDDO, to correct OSA, you do a ramus or body distraction. And in this table, we are talking about this distraction, not the reconstructive distraction of the condyle. We are talking about the body or ramal distraction that will correct the obstructive sleep apnea. Alright, so which do we do first? Do we do the distraction first and increase the mandible, or do we release the ankylosis first and then do the distraction? Or can we do it simultaneously? In the same surgery, can't we remove the ankylotic mass also and put a distractor also, so that one surgery is reduced? So these questions, to answer these questions, we have this table. Alright, so this table says that whenever the AHI is more than 30, that means it's a severe OSA. You will always do a distraction first. You will always do a body ramal distraction and you will correct the obstructive sleep apnea. When the second situation, when the AHI is less than 15, so in both the cases, in children also, in adult also, you can release first. What is the meaning of release first? Release first means you can do the ankylosis release surgery first. Okay, and in second stage you can do distraction. Or the other option is simultaneously you can do release also and distraction also. Similarly, in adults there is option of total joint replacement also. So you can do release first followed by joint replacement, or you can do release and simultaneously release with joint replacement or distraction, like whatever method of reconstruction you are using in adults. Children there are only two options, CCG and distraction. Adults may, you can do distraction, you can do joint replacement, you can do any other kinds of grafts. So it is on you. You can do either release first and distraction later on, or you can do both simultaneously also. So that is the option you have when the AHI is less than 15. That means it is mild OSA. In third situation, when the AHI is between 15 and 30, then you have to see the height of ramus. You have to see what is the height of this region of the ramus. If it is a short ramus, then after release, it will cause worsening of airway. The OSA will worsen. So in that case, you should always distract first. Okay? Whereas if the ramus height is normal, if the child is slightly aged when the ankylosis has happened, the ramus height is almost normal, which requires only unidirectional distraction, then you can go for a simultaneous release and distraction. Alright, so this is the table, this is the protocol that you have to remember whenever this kind of questions come. This is one of the moderate to difficult questions, but this is the protocol that you have to remember of when to do distraction first, or when to do ankylosis release first, or when you can do it simultaneously. Okay. Coming to the next question, how much epinephrine can be administered to a patient with angina pectoris? This is straightforward from Malamade. We have been learning this since a very long time. The answer is 0.4 milligram. Alright, and this is the exact lines from Malamade that Bennett recommends that maximum dose of epinephrine in a cardiac risk, that is ASA 2 or 3 patient, should be 0.04 mg, which is equal to, if you are giving 1:50,000 epinephrine, which usually we don't use in dentistry, you can use only one cartridge. If you use 1:1 lakh, very commonly used in dentistry, you can give 2 cartridges. Or if you are using 1:2 lakh epinephrine, most commonly used in dentistry, you can even give 4 cartridges of LA with epinephrine, usually lignocaine with epinephrine. Alright, so it's a straightforward, easy question. Okay, next question. In the following picture, the device fixed in the child is used for. Now you can see here, this is an old-fashioned bilateral mandibular body distractor. Okay, most probably the child has some congenital anomaly, some syndrome, maybe Pierre-Robin syndrome or anything that causes a small mandible, that causes a hypoplastic mandible. Like you can see here, this is already corrected with the distractor. But maybe the child had a hypoplastic mandible causing obstructive sleep apnea. Okay, it is very commonly seen in conditions like Pierre-Robin sequence. Okay, so in such cases, even in infancy, even in the first year of birth, you can do a bilateral body distraction, distract the mandible forward and correct the airway which is compromised in such children. Okay, so bilateral mandibular, we can see because it is bilateral, it is there in the body region of the mandible. This is the ramus, this is the body, this is the anterior region of mandible. So it is fixed in the body to advance the mandible anteriorly. So bilateral mandibular body distractor. Alright, this is the old-fashioned distractor still used in many institutes. But remember, this image is a distractor. So what are we using it for? To treat mandibular fracture? Of course not. Remember, this image looks very similar to external pin fixation. You must have seen in some of your textbooks that external pin fixation is one of the treatment options in comminuted fractures. Okay, but it is very, very rarely used in the maxillofacial region. I have never seen it, I've never used it. Many of the textbooks have this image because it was used earlier, but nowadays, after the invent of the good ORIF devices, plates and screws, we hardly used X-fix, external pin fixation, in maxillofacial bones. Very commonly still it is used in orthopedics. Long bone fractures, external fixations are still used. But maxillofacial region, it is never used, hardly used. Okay, so this device in image may look similar to the X-fix. Don't get confused. X-fix इतना rare है कि शायद ही आपसे examiner पूछेंगे. Okay, and if it is X-fix, it will be connected, these rods will be connected by an external connecting bar. Okay, that is the difference between a distractor and an external fixator. Okay, distractor mein all these bars will be separate. Whereas in external fixator, these bars will be connected with each other with an external connecting bar. Okay, so that is how you know it is not a distractor, it's an X-fix. But in this image, it's a simple mandibular distractor. To treat obstructive sleep apnea due to retruded mandible, absolutely correct. That is where it is used. To hold the neck affected in Pott's spine. So this is not attached to the neck. Okay, Pott's spine means when tuberculosis happens to the neck, to the spinal bones, we call it Pott's spine. And in that also a lot of skeletal braces are available, but this is not that skeletal brace. It is not attached to the neck. All right, so this is wrong. And to correct cherubism, absolutely not. Cherubism is an auto correcting disorder and it's absolutely not used in cherubism. All right.